Hello and welcome to KS Medical Coding Academy. In this lesson, we will learn about Evaluation and Management, or EM coding, focusing on categories and levels of service. EM services are commonly used captain codes that describe patient encounters in various healthcare settings. Let's begin by understanding the basic structure of EM services and how these codes are organized. Before we begin, please note that this lesson is intended for educational purposes only. Medical coding guidelines are updated regularly. Always verify coding decisions using current coding manuals and official guidelines. By the end of this lesson, you should understand what EM services are, how they are categorized, the key coding elements involved, and how medical decision-making affects code selection. To accurately assign an evaluation and management code, medical coders must understand several important coding elements. These elements help identify the correct captain code category and determine the appropriate level of service. In the next few slides, we will discuss each element individually and understand its role in EM coding. The first coding element is the place of service. Place of service identifies the physical location where healthcare services are provided to the patient. Different settings have different EM code categories. For example, office visits use different code ranges than emergency department services or hospital visits. Understanding the place of service is the first step in selecting the correct EM category. The second coding element is the type of service. This describes the purpose and nature of the patient encounter. A preventive visit differs from a problem-focused sick visit. Likewise, emergency care and critical care services have their own unique requirements and code ranges. Coders must identify the type of service before assigning an EM code. Another important coding element is patient status. A new patient has not received professional services from the same physician or specialty group within the previous 3 years. An established patient has received professional services during that time period. Hospital and facility services may also be classified as initial care, subsequent care, or discharge care. After identifying the EM category, coders must determine the level of service. Modern EM coding relies primarily on medical decision-making, commonly known as MDM, and total provider time spent on the date of service. Certain preventive medicine services may also depend on patient age. The final coding element is the level of service. The level of service reflects the complexity of patient evaluation and management performed during the encounter. As complexity increases, the level of service may increase as well. Accurate documentation is essential to support the selected service level. Let's begin with the place of service. Place of service refers to the location where healthcare services are provided to the patient. Common examples include physician offices, hospitals, emergency departments, nursing facilities, and patient residences. This is an important concept because different healthcare settings use different EM categories and captain code ranges. Therefore, identifying the correct place of service is one of the first steps in accurate EM code selection. The next EM coding element is the type of service. Type of service describes the purpose of the patient encounter. Examples include preventive services, problem-oriented visits, emergency care, critical care, consultations, and telehealth services. Understanding the type of service helps coders identify the correct EM category and apply the appropriate coding guidelines for that encounter. Another important factor in EM coding is the type of patient care. Patients may be classified as new or established, and in some settings as initial or subsequent care patients. Patient status is important because different captain code ranges may apply depending on the type of encounter. Therefore, coders should always identify the patient's status before selecting an EM code. EM services are organized into different categories and subcategories within the captain manual. These categories are based on where the service is provided and the type of care delivered. Examples include office visits, emergency department services, hospital services, nursing facility services, and home visits. Understanding these categories helps coders locate the correct captain code range and improve coding accuracy. Once the correct EM category is identified, the next step is selecting the appropriate level of service. Depending on the category, code selection may be based on medical decision-making, total time, patient age, or other CPT-specific criteria. Accurate level selection is important because it directly affects coding compliance and reimbursement. The level of service represents the complexity of patient care and the amount of work performed by the provider. As patient complexity increases, the level of service may also increase. Higher levels generally involve more complex decision-making, greater physician work, and increased patient risk. The selected level must always be supported by proper documentation. E/M services are divided into different categories based on where the service is provided and the type of care delivered. Common categories include office services, emergency department services, hospital services, nursing facility services, and home or residence services. Understanding these categories is important because each category has its own captain code range and coding guidelines. Identifying the correct category is the first step in accurate E/M coding. Office services are among the most frequently reported E/M services. These include sick visits, preventive medicine services, and consultations. Office visit codes are divided into new patient and established patient categories. Therefore, patient status should always be verified before selecting the appropriate captain code. Emergency department services are reported when patients receive care in the emergency room setting. CPT provides specific code ranges for emergency visits and critical care services. An important exam point is that emergency department codes do not distinguish between new and established patients. All patients are reported using the same emergency department code range. Observation and inpatient services are used when patients receive care in a hospital setting. These services may include initial care, subsequent care, discharge services, and same-day admission and discharge services. The selected code depends on the complexity of care provided and the documentation supporting the encounter. Critical care services have different captain code ranges based on the patient's age. Separate codes are available for newborns, pediatric patients, and patients 6 years of age and older. Always verify the patient's age before selecting a critical care code because age directly affects code selection. Nursing facility services are reported when care is provided in skilled nursing or long-term care facilities. These services include initial care, subsequent care, and discharge management. The code selected should reflect the complexity of patient management and be supported by provider documentation. Home and residence services are used when healthcare providers evaluate and manage patients in their homes or residential settings. As with office visits, separate code ranges exist for new and established patients. Patient status must be determined before selecting the correct code. After identifying the correct E/M category, the next step is determining the level of service. Different E/M categories use different criteria for code selection. Common determining components include medical decision-making, total time, patient age for preventive services, and other category-specific requirements. Understanding these factors helps ensure accurate E/M code selection. For office and outpatient sick visits, captain guidelines allow code selection based on either medical decision-making or total time. The method chosen should be supported by the provider's documentation. This approach applies to both new and established patient office visits and is commonly tested on CPC examinations. Preventive medicine services are different from problem-oriented visits. For these services, patient age is one of the primary factors used in code selection. Different code ranges are available for infants, children, adolescents, and adults. Therefore, patient age must always be verified when reporting preventive medicine services. Consultation services are generally selected using medical decision-making or total time. A consultation occurs when another provider requests an opinion regarding a patient's condition. The provider performs an evaluation and communicates the findings back to the requesting provider. Emergency department services primarily rely on medical decision-making. Providers must evaluate the severity of the patient's condition, review diagnostic information, and determine the appropriate treatment plan. The complexity of the medical decision-making directly influences code selection. Critical care services are unique because they are primarily based on total critical care time. These services involve the management of patients with life-threatening illnesses or injuries. Documentation must clearly support both the patient's condition and the total critical care time provided. Hospital observation and inpatient services may be selected using medical decision-making or time, depending on the service category. Initial care, subsequent care, and discharge services each have specific coding requirements that must be supported by provider documentation. Nursing facility services follow a structure similar to hospital services. Initial and subsequent visits commonly use medical decision-making or time, while discharge services often focus on documented physician time. Accurate documentation is essential for proper code selection. Home and residence services are selected using medical decision-making or total time. These services are provided in the patient's residence rather than a healthcare facility. Patient status should also be considered because separate code ranges exist for new and established patients. Let's look at the major components used in E/M coding. These include history, examination, medical decision-making, and time. Under current CPT guidelines, office and outpatient E/M services primarily focus on medical decision-making or total time. History and examination are still important, but they must simply be medically appropriate for the patient's condition. The history component helps providers understand the patient's condition and gather relevant information. This may include the chief complaint, history of present illness, and other important medical information. Current guidelines require a medically appropriate history rather than extensive documentation. The examination component involves assessing the patient's condition and identifying important clinical findings. The extent of the examination depends on the patient's presenting problem and clinical needs. As with history, the examination should be medically appropriate and support patient care. Medical decision-making, or MDM, is one of the most important concepts in E/M coding. It measures the complexity of the provider's decision-making process. There are 4 levels of MDM: straightforward, low, moderate, and high. Higher levels generally indicate greater complexity and physician work. Straightforward MDM represents the lowest level of complexity. These encounters typically involve minor or self-limited problems with minimal risk and limited data review. Examples include uncomplicated conditions that require simple evaluation and management. Low-complexity MDM involves stable chronic conditions or uncomplicated acute illnesses. Some clinical decision-making and limited data review may be required. Although more complex than straightforward MDM, the overall patient risk remains low. Moderate complexity MDM often involves multiple problems, additional data review, and moderate patient risk. Examples may include chronic conditions with worsening symptoms or situations requiring prescription drug management. High-complexity MDM represents the highest level of physician decision-making. These encounters often involve serious illnesses, extensive data review, and significant risk to the patient. Such situations may require urgent interventions or complex treatment decisions. Many E/M services can also be selected based on total physician or qualified healthcare professional time. This time may include reviewing records, evaluating the patient, counseling, documentation, and care coordination. Accurate time documentation is essential when using time-based coding. Medical decision-making, or MDM, is one of the most important concepts in E/M coding. It helps determine the complexity of patient management and is commonly used to select E/M service levels. MDM is based on 3 elements: the problems addressed, the data reviewed, and the level of risk involved in patient management. The first MDM element is the number and complexity of problems addressed, often called COPA. This element looks at the patient's conditions and the complexity involved in managing them. Minimal COPA represents the lowest level of problem complexity. These encounters usually involve simple, self-limited conditions that require minimal evaluation and management. Low-complexity problems typically involve stable chronic conditions or uncomplicated acute illnesses. These encounters require some clinical decision-making, but the overall patient risk remains low. Moderate complexity problems involve greater physician involvement. Patients may have multiple conditions, worsening chronic illnesses, or new problems that require additional evaluation. High complexity problems involve serious medical conditions that may threaten life or bodily function. These situations require extensive evaluation, urgent decision-making, and intensive management. The second MDM element is the amount and complexity of data reviewed and analyzed. This may include laboratory tests, imaging studies, external records, and diagnostic reports. Generally, the more data that must be reviewed and interpreted, the higher the complexity level. The third MDM element is risk. This evaluates the potential complications associated with patient management decisions. Risk may range from minimal to high depending on the patient's condition, treatment options, and overall complexity of care. The final MDM level is determined using the 2 out of 3 rule. This means at least 2 of the 3 MDM elements must meet or exceed a specific level. The 3 elements are problems addressed, data reviewed, and risk. Understanding this rule is essential for accurate EM coding.